digital health series. My name is Dr. Janice Bailey. I'm Assistant Director of Health and Social Care R&D Division in the Public Health Agency here in Northern Ireland. And I'm saying that because I know we have an international audience today, so everyone's very welcome. The webinars are a joint initiative between ourselves in Public Health Agency R&D Division and led by our Industry Engagement Unit, which is a relatively new part of our team, and the Connected Health Innovation Centre, which is at Ulster University. And the series of webinars and workshops that we're organising are aimed at ensuring greater engagement between industry, academia and Northern Ireland's clinical and health expertise in an effort to promote and increase greater levels of digital health research, innovation and collaboration. So just to give you a bit of a flavour of this, we recently established the Industry Engagement Unit within the R&D division of PHA to act as a front door for inquiries from industry seeking to collaborate with health or commission clinical evaluations and studies within health. So we've been working with CHIC for a bit of time and working up a series of these webinars. The first one today and some others in the series will be focusing on other areas like cardiovascular and respiratory as we go through. We'd like some feedback from everyone on the media that we're using. We're exploring formats and just to see what works best. So we're really happy to get feedback from you on this event, or indeed even if you want to suggest what particular areas we might focus on in future webinars. So in our webinar today, we've got a very ambitious agenda for you. And we're going to start off with, we have got a keynote presenter who is actually coming to us from the other side of the Atlantic, and that's Rick Lee. Unfortunately, at the moment, we have some technical issues with Rick joining the call. So we're going to start with some other parts of the agenda, but that's not to say that we'll hope to get Rick on later on. But we have some local experts to talk to you today, and we've got two people who are very focused on this sort of technology in terms of helping to support mental health and physical health challenges. So that's Professor Siobhan O'Neill and Professor Mark Tully, both from Ulster University. And then we've got three companies to talk to you about technology for wellness. And the three companies are Elemental, Cradle and Healthy Kids. So looking forward to hearing from them. And then we follow that up with a presentation from Professor Maurice Mulvena from Ulster University and Sue Hunn, who's from Digital Health and Care Northern Ireland. This is a local case study of an app that has been developed through funding from both PHA R&D Division, Atlantic Philanthropies, and also from Digital Health and Care Northern Ireland. So it's really gone from the R&D stage through to knowledge exchange and innovation. So that's an exciting example of what has happened here. And then we'll have a short interview about an overview of how CHIC can support industry to access, to work together with us in health and social care, from David Brana, who's director of CHIC. What we hope to do as we go through is to take one question per presentation from those attending via the YouTube or Twitter channels. So if you have a question during any of the presentations, please just type it into the chat window and we'll endeavour to pose it to the relevant presenter. And hopefully, if there's time, and that depends on probably myself and all of the presenters keeping to time, we will try to bring together the presenters at the end for a panel question and answer session. So that's the introduction. And so all that remains for me to do now is to invite Professor Siobhan O'Neill who is a professor of mental health at Ulster University, but also recently who has been appointed as Northern Ireland Mental Health Champion. And Siobhan's going to give us a quick overview of the innovations in mental health. Thanks, Siobhan.
Wonderful introduction. Thank you, Janice. And I'm just going to share my slides here. So bear with me while we see if all of that works. So you should now see my slides. So I'm relying on you to shout if there's a problem there. So one of my key roles as interim mental health champion has been the progression of the draft mental health strategy, and indeed the final version's being prepared right now. And this is a strategy to revolutionise mental health services in Northern Ireland, to fill in all the gaps, recognising that our services are actually quite behind other regions. So hidden within that strategy, an action that doesn't get much attention is Action 13. And it's actually, Action 13 is a very lucky action for everybody here, because this is about implementing a comprehensive digital mental health model, providing digital delivery of mental health interventions into the services across Northern Ireland. Now, my response to the strategy was actually that this action should be expanded, and we should be much more ambitious in regards to what we want in terms of digital mental health. And this presentation really is me showing you some of the possibilities here, and they are really very exciting. But first of all, of course, it is important to emphasize that there will be some resistance to this idea, and even in that action, you can see there that it's a digital delivery of therapies. But if you read some more of the detail of it, it's emphasizing so strongly that this shouldn't replace face-to-face therapeutic interventions. And I would argue that, that's actually not the intention, and that digital interventions can actually enhance the value of therapeutic interventions and be really, really effective. But some people do view it as impersonal and antisocial, and as a way of cutting costs and taking away the humanity out of the mental health services and the humanity and those relationships that are so important, a part of mental health interventions and treatment. But it's absolutely not that. It's something completely different. Digital technology is actually the mode of choice for many people in terms of their communication. Young people tell us that this is how they want to communicate. They're familiar with the online environment. They have smartphones and they enjoy communicating that way. So it is very familiar to that group particularly. And also, as we've seen through the pandemic, many of us have become much more well able to use digital technology in our communication. So it would be unethical not to consider this as a method for delivering mental health interventions. I think some of the early online interventions for mental illness were received very badly and didn't work very well. They were mainly psychoeducational, providing people with information. Again, that's not a treatment in and of itself, and it didn't really cut the mustard in terms of digital mental health. There was also the move towards the online presentation of CBT, cognitive behavioural therapy. Again, that worked if people engaged with it, but that engagement was crucial. And many of the studies found that, particularly around the Beating the Blues programme, when it was first introduced, that the uptake was very, very low. And that was why it wasn't as successful as it should be. So mental health inequalities are a huge issue in Northern Ireland, as with other areas, and digital technology can be used to address mental health inequalities. So it's about supporting people to connect. That could be particular minority groups to connect with people who are like them, to feel that sense of connection, which in and of itself can be very therapeutic. It also helps people with very different physical conditions and chronic conditions to connect with services and to receive services. It also improves accessibility in terms of regional inequalities and the rural-urban divisions that we're seeing right now. And it also allows people to discuss very, very sensitive issues using technology. For example, using chatbots. We know that people open up more quickly when they think they're talking to a robot rather than a a human being. So that can actually enhance the therapeutic process and speed up the delivery there too. It may also reduce barriers to access, including stigma. And that's a very, very important thing, because we know that that is a barrier for people accessing mental health services. So what I would like to see in terms of our mental health strategy is that we would be using digital technology at every step. So it's much broader than telephone or online counselling. It's about information and education, online resources, webinars. It's about the in-service use of technology, where we can have digital correspondence, self-service for appointments, digital assessments. So we do a lot of that paperwork in advance. It's also about complementing the treatment that's provided with things like psychoeducational, the ecological momentary assessment, which I'm going to talk about in a wee minute, things like safety planning, care plans for people, that can all be done online, activity monitoring, chatbots, all very, very useful. There's also standalone 24/7 interventions that are available on a person's smartphone, and this is very useful in the moment that the person is struggling with their mental health or struggling with their feelings or emotions. It can be used along with the talking therapies and suicide prevention treatments. There's also the gamification for knowledge. So it's raising awareness of the symptoms of mental health problems and how to ask for help, and doing all of that through a game. But also the gamification, which is a treatment itself, which is around programming the behaviour and thinking about those compulsive behaviours, suicidal behaviours. There's games that can actually be really, really effective there. And I'll give you a couple of examples now in these next slides. So EMA, Ecological Momentary Assessment, this is where we use data collection in real time in the natural environment. So it could be ambulatory monitoring, continuous physiological data, and we know that things like heart rate, the galvanic skin response, all indicates whether or not we're feeling stressed or under pressure. We know that our physical activity is related to mental health, and that can be monitored online too. There's also the online monitoring of moods through a daily diary, so that people can start to make those connections between their activity and their moods and their thoughts and their feelings, which again provide a fuller picture. There's digital phenotyping, which is a moment-by-moment quantification of that person's activities and actions whilst they're at home, whilst they're in their everyday normal environment. And this is so powerful because it decreases recall bias. So when a person is in the office setting and they're trying to remember how they felt over the past week, it can be very unreliable. So this is about the behaviour in the context in the person's home, which is, it just brings the whole thing to another level. And it provides opportunities for earlier intervention, because we can highlight at an earlier stage when behaviours or the physiological indicators are starting to show that there might be a problem. So I've gone over my time, so I'll not do these wee slides. I'll just move to the end one. These are some examples. So what are the challenges here? Well, there's the impact on staff of introducing digital interventions. There's the quality, there's data storage and ethical issues. There's a social effect on the family and carers and how we involve them. The importance of that relationship shouldn't be lost. There's safety issues around moderation. There's issues about inequality in terms of digital poverty and access to Wi-Fi and data. And finally, there's this idea that these constant reminders of your mental health may actually have a negative health impact, and the impact on clinical care too. So hopefully that's given you some food for thoughts, and happy to take questions regarding these points. Thank you.
Thank you very much, Siobhan, and that was quite that was a very interesting presentation, but I wasn't quite expecting you to finish so quickly, so you might have got away with a couple of other examples if you'd wanted to. But
I can do those if you want, Janice.
If anybody has anyone any questions at this point, because I'd be happy to take a couple. Mark, are you wanting to ask a question, or have you been just brought in there now? Okay. Well, I did have a question actually, Siobhan, if you don't mind. And I was just wanting to ask you, to what extent or how far away do you think we are from these types of digital interventions being available routinely in the health and social care in Northern Ireland?
I think they should be introduced very, very quickly, Janice, as we develop a regional mental health service and make all these changes that we're going to make. I think this should be embedded in that service right from the very start. So I think with the Encompass system, we should have data across all of the trusts that's available. We should have systems that are set up to allow us to book our own appointments. So I would like to see that happening really, really, really quickly and as soon as possible, because there's so many savings that can be made with these sorts of interventions, and there is such an appetite, particularly in younger people. So as we're making the changes, and there really are so many changes that we're making at the minute in primary care and delivery of mental health services, I think it would be wise to start thinking about this right from the outset as we're planning everything else, rather than trying to shoehorn it in later, if you know what I mean.
Okay. Any other questions from the audience? Okay.
Yeah, there's actually a few questions that have come through and a few comments. If you don't mind, Siobhan, I can direct some of them to you. Jackie Morton was specifically asking about chatbot opportunities and the reason why people open up to chatbots a bit more than probably they would to a real person. I don't know whether you want to comment on that, Siobhan.
Yeah, of course. So chatbots, Morris and I are actually working on a number of chatbot projects, so he'd be able to tell you more about what that entails. And it's a way of discussing your mental health without feeling that you're ever going to be judged, or that that anybody's going to be making an assessment about you as a human being. And many of the things that affect our mental health are things that we're quite embarrassed about. And it's like a sounding board. A chatbot can be a sounding board to let you know whether or not what you're feeling is what you would expect, or whether it's something that you should ask for help for. And it can also help direct people to the best sources of help. And chatbots can, they can detect red flags, for example, when the person would then be escalated into a face-to-face conversation with somebody. So it's got so many different uses, but people can use chatbots every day just to suss out things, to get feedback on what they're doing for their own mental health as well, and as a way of detecting whenever things are starting to slip for people who live with mental health problems. And some of the projects we're doing have those kind of chatbots embedded in there.
Okay, and can I throw one more quick one at you from Stephen McPeak? Stephen has asked, what are the main barriers to the uptake of any of these digital solutions? Is it data protection, trust, GDPR? What are the sort of potential roadblocks of sort of further uptake?
I think a lot of people still want the face-to-face counselling. There still is that attitude that if you have a mental health problem, that the main treatments are either talking therapies or medication, so other types of non-pharmacological interventions are rarely considered. And I think that is a big barrier. I think people are concerned about how their data is used, particularly when they're talking about very personal or sensitive issues. But a lot of these types of interventions are monitoring behaviour, and the data is already there in their phone, so it's not actually, it's very, very secure. So it's about getting those messages across. But we haven't seen too many barriers. It's all about the person's familiarity with digital technology and their comfort in using technology, and what way they prefer to communicate. I think those are the key factors that will influence whether this is part of a solution that will work for a particular person.
Excellent, thank you. So Janice, back to you if you want to unmute yourself. Siobhan, I'm going to remove you from the stream. Thanks very much for your contribution and taking those questions.
Thank you.
Thanks, Siobhan. So now moving on to another area in where innovation can play a very important part, which is around physical activity. And I'm going to introduce to you Professor Mark Tully, who's Professor of Public Health at Ulster University. And he's going to talk to us a bit about insights where innovation can support activity, I hope. Welcome, Mark.
Okay, Thanks very much, Janice. And I've got a few minutes really just to set some context for what we will be considering in terms of preparing our digital solutions. So this sort of will sort of complement what Siobhan has been speaking of all along there. I'm hoping you can see my slides okay. The key in this, I think, is the context we live in is a world in which we've had such disrupted routines that we haven't seen before. So if we look at the Google mobility data from April to December of last year, what we see is that we had a dramatic decrease in the amount of time spent in the workplace, where most people weren't going into workplace, a 70% reduction. This is for Belfast in people spending time in their workplace. And that has slowly recovered over time, but certainly hasn't come back even to January of last year levels. And concurrent to that, we had a massive increase in the time we spend inside our homes. And that disruption to our daily routines is bound to have an impact on our health-related habits. One of the positives, I think, has been the up increase in the use of parks, particularly parks in our local neighbourhoods. And I'm going to touch back on that a little bit later on. But how did people respond in the initial phases of the pandemic? This study looked at the Google Trends searches for terms like exercise and related terms. And what we saw was that the early phases of the pandemic, we saw significant increases in people searching for terms related to exercise. And that probably coincided with some government recommendations during lockdown and restriction periods that people should undertake periods of exercise per day. So there clearly has been some interest or maybe some intention around activity, and we were really interested to see whether that followed through into specific behaviours. So we conducted a very large systematic review with 66 articles representing over 86,000 people from right across the world, and studies that had reported changes in physical activity across the probably first 6 months of the pandemic. These studies represent 45 of those studies were in healthy adults, and in those we saw significant increases in leisure time, albeit quite small. But overall, the populations, over 50% of people reported reducing their physical activity as a result of the restrictions that were introduced after COVID. Similarly, for children, overall, over 50% of children were reporting declines in physical activity. And concurrent to that, we saw nearly all studies reported increases in sedentary behaviour in both adults and in children. So the first question is, has the pandemic affected our behaviours? And it has, and quite considerably, if we look at our physical activity and our sedentary behaviour, both of which are independent risk factors for over 20 common chronic conditions. We then conducted a few country-specific studies. So this study in the USA was 3,500 participants from right across the USA. And we asked them to recall their activity level prior to COVID and their activity level post-COVID. And we found something very interesting in this. For those who reported being active before COVID, we saw a significant reduction in the number of people or the proportion of the population who remained active. That wasn't the case for those who were inactive before COVID. So the pandemic restrictions didn't seem to have a huge influence on those who were inactive, probably because they took low levels of activity to start with. But certainly for those who were active before, what we saw was a significant reduction in their activity. So who has the pandemic affected most? Well, certainly in terms of the opportunity to undertake exercise and activity, those who were active before, those good habits have been broken. We also looked at the kinds of people, the correlates of that, and those who were reporting higher levels of depressive symptoms or anxiety symptoms or lower mental well-being were more likely to decrease their activity as a result of the pandemic. Siobhan referred to some of the inequalities, and we see these inequalities emerging in behaviours as well, particularly in terms of those with high levels of anxiety or depression. In the UK, we conducted a similar study, and we've got a range of papers on that. And I think best to represent it like this. We were really interested to see across both mental health and some of the health-related behaviours like diet, alcohol, smoking, sexual behaviour, and physical activity and screen time, what would happen. And the common theme across these studies were that certainly during our first wave of the pandemic, those who were impacted the most were more likely to be women, more likely to be from a lower socioeconomic position, and younger, in their 20s and 30s, and to have at least be reporting higher levels of anxiety and depression. So not only those who are anxious during the first wave of the pandemic, but also we see younger people of lower socioeconomic position and more likely females seem to be affected most. And I thought it might be timely to show you some unpublished work. This analysis was completed over the weekend, so these graphs are really quite new. And what we wanted to see was what happens over time. So that data, most of the published data is in the first wave, and this is sort of from the first wave from before, which is T1 on the left, the middle, which is during the first wave, April, May, June time, and then going into the summer and beyond. And what we see in the top left graph here is that we've seen that activity levels have started to bounce back after a sharp decline, but they haven't even bounced back, and this is last summer, they weren't even bouncing back to the sort of pre-pandemic levels. Sitting time has increased significantly. Well, we've seen that from our review, but those aren't rebounding anything like what they should be. Saturated fat intake as an example, but we hear a lot about the COVID stone that people are putting on, and we saw certainly fat intake go down initially, but then come back up again. We have seen some impact of the pandemic on anxiety and depression, but what we've found was that certainly the people that we've surveyed over time have been quite resilient, and that their anxiety symptoms are starting to come down again as the pandemic has progressed into easing of restrictions. So there's certainly some people who will rebound quite quickly, and some of those who won't. The other group we were interested in trying to map was what the impact might be on children. And in this narrative review, we've pulled out all the available evidence before the pandemic as the impacts of isolation on children. And we see physical activity and screen time in the middle of those, but we see quite a range of other interrelated problems. And I guess the next point I want to bring out is that a lot of the issues that will have been caused by the pandemic are interrelated. So socioaffective problems, education and mental health problems all relate together. And so we want to look for solutions that might address each of those equally, in addition to the declines in activity and perhaps increases in obesity or at least adiposity that we might see in children. So I think that's a very interesting cohort. Complex problems may be arising, certainly in some of them, but there may be solutions that have a digital nature. So some reflections on our work to date in terms of our surveys we've now conducted in about 10 different countries, was that we've seen a significant impact of the pandemic, at least in the early phases, on health-related behaviours and on mental health. And that I think we now need to start to plan how we might reintroduce some of the habits we had previously that maybe haven't rebounded back to the way they should, certainly those good habits, for their physical and mental health benefits. I do think there's a small opportunity to work here. Our environment we live in has changed. Many of us are still remote working and may maintain that for some time. We've seen a greater use in the parks data of home neighbourhood environments and some reduction in car use. And so to me, those are the levers for change that we might look to act on to maintain or indeed further increase those health-related behaviours. And I wanted to finish with this. This is a commentary we wrote around the impact of the built environment. And that was that we've seen the COVID crisis has changed activity patterns and widened inequalities across activity in a number of other areas. But that really, to address that, we probably need a synergistic approach. So we take it from the kind of top down, the physical environment we live in, the social environment we live in, and beyond that to try to make changes to people's working lives, recreation lives, and home lives to improve their health and well-being. I'd like to acknowledge a long list of international collaborators on the papers that they've worked on with us, and thank you for listening. Happy to take any questions.
Thank you, Mark. So I'll invite the audience if anyone has already posted any questions. Patrick, have you any questions there at the minute?
I would say there's no questions, but there's a very healthy discussion going on in the chat room. So please keep engaging with each other. I didn't see anything specifically coming in from Mark, but everyone's very active there and everyone's very engaged. So you're off the hook, I think, Mark, in terms of that, of any direct questions at the moment. And
I'll ask you one if you like. So I was just going to ask you, in terms of the different stakeholders that might be involved in this work around encouraging more, health-related, health beneficial behaviours, Mark, and who you think could be involved in those conversations.
I'm not getting your question, Janice. It's breaking up quite a lot on me there.
Okay, I was just asking about what stakeholders might be able to be involved in those conversations about adopting more healthy behaviours.
Yep, perfect. Yep, got it that time. Okay, so I guess the stakeholders relate to the target group that you're looking to address. I mean, we've seen a lot of focus, and I think we'll hear something later from Healthy Kids in terms of schools. And I think certainly for children's schools and indeed a sort of a co-responsibility between schools and families are really important. I think the other thing to note is certainly in Northern Ireland, and I know a number of places elsewhere, are going towards sort of a community planning approach, where we're trying to involve local communities in designing and planning their neighbourhoods. We've all seen the benefits of living in areas where we can access green space in Northern Ireland, where we have really, quite good access to parks. And so I think local neighbourhoods, local communities, and the community voluntary sector have a really strong role to play in advocating for good design to encourage people to walk, cycle, and play safely in home neighbourhoods. And really going forward, I think that's a really very healthy model, both in terms of activity, but also in terms of the social connections and social support that we can create through that physical infrastructure. And then I think, a number of people have moved far more towards digital platforms. And I think using the evidence base we have to inform those digital health solutions is very strong. So I think academics have a role to digest the evidence we have created over a number of years and translate that into actionable steps that can be introduced into digital platforms.
Sorry, thanks, Mark. Any more questions coming in, or?
I've lost John.
No more questions for Mark. So, Mark, thanks very much for your presentation. Sorry for some of the audio dropouts there, but I think we could pretty much hear you all the way through your presentation. So, thanks again.
Yeah, thank you. Thanks, Mark.
Janice, I'm delighted to let you know that Rick Lee has now been able to rejoin us from across the Atlantic. Rick, can you hear us?
I can indeed, yes.
You're very welcome.
Absolutely. Thank you very much for joining us, Rick. And I'm going to do a little introduction for Rick here, because he is our keynote presentation of today, and we're hoping he's going to give us some of his leading thoughts on this area of promoting wellness. And Rick describes himself as a healthcare deal junkie. I'm intrigued to know what that means. But he trawls in the early stage healthcare investor domain as an angel investor, board member, advisor, and connector to other players in the ecosystem. He's been an active trend spotter, first in the mental health field in the 80s, then at the dawn of disease management in the 90s, launching one of the first digital connected wellness businesses in 2009, and now actively involved in the food as medicine dialectic that is sweeping into healthcare. Rick unashamedly interjects performance art into his business life as often as he is permitted. And as I can see, he is demonstrating one of those health-related behaviours, as I believe he's walking on his treadmill while he's speaking to us. So, Rick, you're absolutely welcome, and delighted that we've got you on screen now. And I'm just going to hand over to you and let you take it from here.
Okay, and that means I can put this presentation up here and everybody can see it. Janice, is everybody seeing this?
Rick, you are sharing your whole desktop, so that's why we're kind of seeing this infinity image. Do you want to just...
You're not seeing the PowerPoint?
No, we're seeing your desktop, which is the actual broadcast that we're on at the minute.
Oh, I see. Okay. So let's try this. Is that better? What we're demonstrating with absolute certainty is that I'm a digital neophyte and incapable of working with technology. But if you can see this slide, let me know, and I'll do it this way.
No, we can't see your slide. When you go into the share screen option, there's an option either to share your desktop, share your application window, or share your Chrome window.
Yeah.
So if you want to stop that, if you want to stop screen and then try it again.
Oh, okay. I'll stop screen. Try it again.
Share screen.
Share screen.
Application window.
Yeah. Entire screen, and it's not allowing me to share it.
You cannot see your application window. Let me...
I get 3 options to share: entire screen, window, or Chrome tab. And none of them highlight on the share button when I go to them.
Slides from
oh, okay.
Top and then
Okay, I got it. I think. You seeing it now?
No, we're still seeing the same thing. Let me load up your slides from my side, Rick, and then you can ask me to just...
That's a good plan.
Just hold on a second.
Yeah.
Okay.
Okay. So my last message in this short 10-minute presentation is to avoid friction. And this is a classic example of friction that is so frustrating that people bow out of wanting to use technology. If I want to get well and I want to use technology to get well, and the technology is not friendly to me, then I'm not going to get well. Next slide, please, Patrick. So the most important thing here is that it's not about a disease, either the disease of obesity or type 2 diabetes or cardiometabolic syndrome. Those are all diseases related to wellness and the lack of wellness in a person's life. Throw in the fact that there's mental well-being, as we heard from our last presentation, and you're now talking about the whole person. Next, click. So let's not divorce the head from the body. It's both the mental well-being and the physical well-being that make a whole person whole. And these are some of the conditions that we're dealing with. Next click. Obesity is going to be half of all adults, or type 2 diabetes will be half of all adults by 2050. 2/3 of us are overweight or obese. Only 3% of our total healthcare budgets, at least in the United States, only 3% is aimed at prevention of disease instead of treating disease. Whereas in the Defense Department, we spend $700 billion every year to prevent war instead of to fight war. So we have a prevention bias that is in favor of preventing war, but not in favor of preventing war on disease. Next slide. Health education is not the solution for this. Click. It's too generic. Click. One size doesn't fit all. And last click is it has to be individualized and personalized. In the healthcare profession, we have made the mistake of thinking that our words are like pearls of wisdom that consumers and patients are longing to hear. And it couldn't be further from the truth. The truth is, next slide, you got to be talking to me. And as Robert De Niro said in Taxi Driver, are you talking to me? If you're not talking to me, I don't want to hear your message. So if you send out a white paper on type 2 diabetes that goes to 5 million people, I'm not even going to read it. I'll throw it right into the trash. Precision medicine offers us the opportunity to conform our message to specific target groups and individuals. And that message has to be individualized so that I feel when I receive it, it's all about me. Next slide. And you got to know where they're coming from. So if an artificial intelligence platform that is trying to personalize messaging, if it doesn't understand these distinctions that some people have anxiety, others have depression, some have shame, others are frustrated or feeling a lot of stress. And next click. Because it's all about me, you've got to get down into the weeds and understand the personalities that you're trying to communicate with. Next slide. So there's a science of this. It's called the science of behavioral economics. It was featured in Daniel Kahneman's Nobel Prize-winning book, Thinking Fast and Slow. And it has to do with the following. Let's do all the clicks. These concepts: loss aversion, endowment effect, anchoring, more, choice architecture, and one more, status quo bias. So these are just some of the concepts introduced by Kahneman in messaging, communicating, and really understanding that we people are predictably irrational. We are predictably lacking in reason. So if you come at me with a logical message, there's no guarantee that I'll logically receive that message. I may illogically and predictably be irrational in the way I respond to the message. We see it with mask wearing in America. Some people don't hear the message if it says you need to do this for your own health, and what they hear is you're losing your freedom. They're being irrational, but they're being predictably irrational, and that's where health professionals deviate from marketing professionals, communication professionals, the people who understand how irrational we human beings can be. Next slide. There are many, many devices that can capture information to deal with our irrationality, but they have to be in the passive data capture mode as opposed to actively capturing. So you can see I'm on a treadmill, and all of the steps that I'm accumulating at the moment are being reported seamlessly, passively into the cloud and into a personalized, individualized data set just for me. If I only get 3,000 steps today, that message will come back to me at the end of the day saying, what were you, sitting on your bum and not getting any exercise? Or did you have something that interfered with your exercise, like a tragic event or something meaningful that is worthy of stopping my daily exercise? That's called personalized messaging. That's called precision medicine. And that's what we need to see in the wellness space. Next slide. Because convenience is the new quality. And if it's more convenient for me to go down to the emergency room and sit there for 4 hours before I get seen for a suspicious lump on my arm, then our technology has failed dramatically. Technology has to be friction-free. It has to break down the barriers of communication rather than increase them. And if consumers don't know how to find your portal, if they don't know where their username is or their password, they've forgotten it. If they don't know how to download your app, these are all barriers to getting participation from them. And that is your job, is to activate and motivate those consumers to pursue greater wellness. Next slide. One way to do it is with gamification. Click. It increases stickiness and it sustains engagement. So gamifying apps or gamifying the portal, gamifying messages, they all have worked with the younger generation and also with some of the older generation, as you can see with Farmville. Next slide. Oop. And don't hide behind HIPAA, privacy, or security concerns. This is taking over the financial interactions now. Those were meant to get rid of paper and move to paperless communication between financial institutions and their consumers, and it's having the opposite effect. The people are getting lost in two-factor authentication and all sorts of other things that are challenging for the non-digital natives. Next slide. So we are actually finding ourselves not in the process business, but in the outcomes improvement business. And that's really the bottom line here. If I get you to walk on a treadmill and get 30 minutes of exercise, meaningful exercise where you increase your heartbeat, if I accomplish that on a daily basis, that doesn't necessarily mean that I'm improving the outcome of what your goal is. Your goal may be to be able to exercise so you can continue to smoke. And if I don't know that that's your goal, then the processes that I'm throwing at you are not necessarily aimed precisely at your goal of continuing to smoke. So we have to figure out what each consumer wants to do, understand their motivation for doing that, and then communicate with them around that theme. Next slide. So at the end, it's all about making it easy, making it friction-free, breaking down the barriers so that we can all live a happy and well-being and fulfilling life that includes both mental and physical well-being. Thank you.
Thanks very much for that, Rick. Sorry for the technical problems, but I think we got there in the end.
We did.
I'm just going to bring Janice back into the stream. I think you were causing some of our colleagues here at Ulster University to sweat a little bit, Rick, with your exercise, so that was excellent. Good to remind you to get out for a walk. Janice, I think you might be on mute at the minute.
I shouldn't be. I tried to take it off. No? Can you hear me?
You know, that's okay. Yeah.
Thank you, Rick. That's a very interesting presentation. And I have a question, something that maybe you could comment on. So something I heard about at one of our conferences a while ago was just-in-time interventions. So, you know, the effect of something pops up when you're walking past a park to suggest maybe it'd be a good idea to go in there. Have you come across those, and what would be your thoughts on those?
Yeah, the communication that should be coming to individuals not only needs to be personalized and individualized around them, so it's all about me, but it also has to come in snackable bites. And the best time to do snackable bites of information is when it's at the right time, right place, right intervention. So this is what, go back to retail, where a lot of these tricks of the trade are being developed in behavioral economics. If somebody's walking by a store and they get pinged on their smartphone that something they've been shopping for is in that store, that's called just-in-time marketing. And that's the kind of thing that we don't do in healthcare that we should be doing, as our friends in the retail business do routinely. They mine the data, they get to understand what makes me unique and special, and then they communicate the hell out of that to me specifically, so that I get snackable bites of information that are just in time for me to act on them.
And people need to, accept then that they're going to be visible at all times in some way. So that could be a privacy issue for people, and that might be what's holding that back, do you think?
I think that privacy is overrated. I think that there are people that want to improve their lives, and if you give them an incentive to participate in your specific solution, they're willing to break down the bounds of privacy in order to let you in if they deem your intervention something that they want to engage with.
Yeah, people put lots of things on social media that they don't really think too carefully about sometimes, I think. Does anyone else have any other questions that they would like to ask Rick?
Yeah, I'm just trying to follow the comments in the chat room. It's a lot of stuff coming in there, so maybe difficult to pick out any specific questions for you at the minute, Rick. But if you could hold on to the end of the broadcast, then maybe hopefully we'll have maybe a chance to come back. And,
I shall.
Rick, thanks a lot.
Well, listen, thank you so much, Rick. That's been great.
Thank you.
And okay, so next up we have a series of presentations from colleagues from local companies to showcase some of the capabilities that exist within our own business sector here in Northern Ireland that focus around managing, monitoring and promoting wellness. So the first of the three is Jennifer Neff, and she's from a company called Elemental, who work in the social prescribing space. So Jennifer, I think I saw Jennifer there coming up quickly.
Hi, Janice.
Welcome, Jennifer. Lovely to see you. And I'm going to hand over to you now so you can tell us all about what you do.
Brilliant. Thank you, Janice. I'm going to see now if I can do this after watching Rick try to do it. I'm a little bit nervous. Entire screen, no. Window and Chrome tab. I'm going to go for Chrome tab.
Are you running from PowerPoint, Jennifer?
Yeah, I'm going from my Google Drive.
Okay, so if you click on the share, then it gives you the options, as I said, to share either your desktop, your application window, or Chrome tab. Okay. So if you click on share.
Yeah, I know if I do this, it's going to be the same thing that came up with Rick, isn't it? How's this look?
That's Rick. Let me see. Yep.
It's the same as Rick. Same as Rick's, right? Hold on. Let me try it again. Video file? No. So, share screen. Share screen. Oh, here we go. I think I've got it. You see that?
Let me see. Yeah.
Yes. It's made my day. Look, hello everybody. I am delighted to be here today, and I'm just talking about what Elemental have been doing in this space over the last few years. We've been at it now for decades, actually. Leanne Monk and I used to be community development workers, and in the time that we were doing that, we learned that it wasn't as simple as just handing someone a leaflet. It wasn't as simple as saying, "Oh, here's a great app that we have. Sign up. This will solve all your problems." It's not just about signposting people to a council website with all the things that you can do to improve your health and well-being, or putting a poster campaign up on a billboard, because some people are living really really difficult lives, and if they're struggling to pay their rent and have fear of being evicted, they might not necessarily be that up for joining the kind of family fitness program or things like that. So we learned loads through our time in community development. We also learned that community and voluntary sector play a massive part in community health and well-being, and it was really proved as well over COVID. But the community and voluntary sector doesn't always get the credit for that they deserve. They don't always get the money and the funding and the sustainability that they deserve. So Leanne Monk and I said, let's do something about this. Let's be able to connect. There's lots of people out there, and there's lots of health inequalities. There are lots of programs and services and activities that make a difference to people's lives. Let's connect the two together, but let's understand that a lot of people need some help to engage, because they might be anxious, they might never have done an activity before, and they might need some support along the way. At the same time, there was a movement that had been growing called the social prescribing model of care. And social prescribing is all anchored around a social prescribing link worker. And the social prescribing link worker is there to have a conversation with someone, to find out what matters to them, to find out what they're struggling with, but also find out what they enjoy, to talk about maybe setting some goals, and to help them navigate through the community to find out about the different types of services and programs that are there that are going to help that person. They also help people to understand the difference that it's making to their health and well-being. And if someone actually ends up dropping out of something, they're there to help them, try to encourage them back in and maybe try something else. So thankfully, the social prescribing link workers are being funded across Ireland and across England, Scotland and Wales. The NHS has funded 1,000 of them already, and there's another 1,000 that are going to be funded in England. Scotland's the same. And in Northern Ireland, there's amazing examples of social prescribing in action. There's the Spring Project, the Healthy Living Centres are delivering that. And there's also MEAP project, and there's some connected communities projects as well. But social prescribing also happens in places where there's not necessarily a social prescribing link worker, but it might be someone who's like that, like a community navigator or a wellbeing team. So as you can imagine, their demand for social welfare legal advice and debt advice is really important at the moment. Also food banks and other things like that is really important. So it's trying to get the support to people at the right time. So you can imagine as well, that's really complex when you're doing that with just paper or really, really old systems or spreadsheets. So what Leanne and I developed was a platform that was going to help do that. So it's a core platform. It's helping people to receive referrals, because a lot of people receive referrals from emails, from paper, and it's just really cumbersome for the organizations delivering community care and health to be able to do that. And sometimes people can get lost along the way and maybe fall through the cracks. So we said, let's help the community and voluntary sector to really standardize how they receive their referrals. So it's a cloud-based platform. It can responsive, so it can be on iPads or laptops. There's a two-way connection with GP systems. So in England and Wales, GPs can actually make referrals directly into the community and voluntary sector, and there's little SNOMED codes that push back into the GP systems again. So on the patient's record, it says social prescription offered, whatever the reason was for the referral, who it was made to, did the person accept it or decline it, who was the social prescribing link worker. So that helps to give a better kind of understanding in terms of where the gaps are. But that's not everything, because people need to be able to self-refer themselves in a really simple way. So we developed just a little button that can be put onto a website to say, if you'd like to self-refer yourself into someone who can help you with whatever help you need, just fill out this little form. Sometimes the GPs actually send out the self-refer form as well, so that their patients can actually get the support from the link workers, because some of the social prescribing link workers are actually based in GP practices as well and primary care networks. So there's lots of reporting as well that we can do around that. This is just a quick example of a typical kind of journey. So a referral can be made by either a GP through a clinical system. It can be a community pharmacist makes a referral through the Elemental portal. In Limavady, we're actually talking about maybe barbers and some of the local councillors being able to make referrals for people. And those referrals then are made and they're received then by the social prescribing link workers straight into their Elemental inbox. They can see what the reason for referral is. They can see some of the information. Maybe someone has recently been bereaved and things that they need to be aware of. The link workers can then manage their caseload. This helps as well because sometimes there's a lot of referrals coming for the link workers. So they can actually say, look, we need more funding. We need another 2 workers here because we're being overwhelmed at the moment. They can do all their baseline metrics and find out what's important to that person as well. So they can measure anxiety, social isolation and loneliness, depression levels, things like that. And then they can co-create a plan together. So there's a built-in live and interactive database of services. So you can see that the person wants to do something for beginners, for example. They only want to do something maybe a mile from where they live. They only want to do something that's free. So that makes it really bespoke and tailored to the person. And then the social prescribing link workers can support the people to engage in those services. Next time they see them, they do a follow-up with them. Maybe they find out they didn't enjoy that particular class and they look for something else. Or maybe they say, that was absolutely brilliant. That really, really helped me. And that feedback goes in so that others can get that feedback as well. So the link workers can track and measure that well-being along the way. And then ultimately we can show the difference to the person. What's the difference to the health or the community? And what's the difference to the health and social care sector? So I'll show you what that looks like. This is one little model, just shows you referrals coming from different places in Care Merseyside. And then their link worker team then can help people. And then there's a lot of programs and services that they provide. And they also partner with other organizations as well. This is the little kind of quick overview in terms of the bespoke element of it. You can filter down here, the left-hand side. This list gets shorter and shorter, so you can do the Zumba class, or it could be the debt advice that you need. Quickly, you can just press this little button if the person's up for it, and a referral is instantly sent. Also, if you signpost someone to something, that can be logged as well on here as well. This is an example from Care Merseyside. They've been tracking the anxiety of the community that they support in Knowsley, and over a 2-year period, you can see the anxiety score was really, really high, and then it was dropping down. It went up slightly there during that second wave of COVID. They have provided a magical mindsets course for their community, and as a result of that, the anxiety levels have dramatically dropped. So it just proves shows that the difference that they're making and that particular activity is making, and then they can go back to funders and say, right, we need to be able to do this because this is working in our particular community. And then finally, this is just some of the data and the analytics that comes through. When you've got people making referrals, you've got reasons for referral, you can even drill down into a street by street to be able to show, look, this is an area that has an issue with maybe physical inactivity or social isolation. Are there enough services in their area to be able to tackle this? Can people make more use of the green space, etc.? And then just finishing off, because I'm conscious of time, who uses Elemental? So we're working with over 55 health trusts in England and Wales. We work a lot with the community and voluntary sector, would be the second biggest user of Elemental. We also work with housing associations. We're even in further and higher education colleges here in Derry, the Northwest Regional College. We work as well in universities and prisons. So anywhere that you have a community of people and you have an offering of services, we can be used in those settings. But what we're most proud of is that nearly 85,000 people are being supported through social prescribing by people using Elemental. And for us, the fact that nearly 10,000 GPs are using and social workers are using Elemental is fantastic, because that means that more referrals are being made to nearly 1,900 social prescribing link workers all over the country. We've seen a massive increase as well, just finally, on demand for using digital and for using Elemental. Our system is mainly for the workforce that support people. We are starting to see more people, individuals, children and young people and students and things that are looking now to use Elemental, but we wanted to just make sure that it was a system that initially could be used by the stakeholders within health and well-being before then it's offered out then to others, helping them to be maybe more digitally enabled. So finally, get in contact with me. There's lots of great things that are happening out there. We're seeing great stuff in North Wales. There's Macmillan Cancer Hubs, and there's Long COVID Hubs, and there's Green Social Prescribing Hubs. So you can get really, really kind of niche on this in terms of what you do. But it's a system that's there for any key player and stakeholders in health and well-being and communities. Thank you.
Thanks, Jennifer. That was a great description of everything you do in a very short space of time. So thank you very much for that. And I'm absolutely intrigued by hip hop knitting and the heavy metal choir. And I'm just wondering how I can find my way to any of those if they actually exist.
We'll put you in contact. There's even laughter yoga, and there's all kinds of things. But, you know, on a more serious side, that there is so like the social welfare legal advice now, and it's just so important for so many people. So we're starting to see that as being one of the biggest demands, unfortunately, for people who are just trying to survive with everything that's happening now as a result of this next phase of COVID. But yeah, if anybody ever wants to see a demo of how it works, or have a chat about what they're particularly doing, we're doing a thing in North Wales where providers of activities and services are all coming together with the social prescribing organisations, and now the social prescribers are going to have a whole raft of things that they didn't even know about that existed. So providers are going to get on board and be able to receive referrals as well. So we're having an event on that on the 11th of May about that, if anyone wants to have a nosy and join and see what they're doing over there.
Great, thank you. Patrick, have you any other questions coming in for Jennifer?
There's a lot of questions, a lot of activity there. So what we'll do, because we're running a wee bit behind schedule, Jennifer, if you can hang on to the end of the broadcast, then maybe we can put some of those questions towards the end. But thanks a lot for your fantastic presentation, Jennifer. Sorry we didn't get to do a quick demo with you from the start, but it all went.
No, don't worry. Thank you.
Okay, thank you, Jennifer. And next presenter we have is Rupinder Singh, and from a company called Cradle. And I'm looking forward to hearing from Rupinder because I want to learn a bit more about what Cradle does as well.
Thank you very much, Janice. Good afternoon, everyone. I'll now attempt to share my screen. So here we go. So I will pick here, and if you can let me know if you can see that, please. Can you see that okay, Janice? Hello, Janice? Can you see that okay?
We can see your presentation, Rupinder. You can start.
Okay, thank you. Just go back to that. Okay, so the name of our company is Cradle, and the name of our solution is Connect. I'm the Chief Strategy Officer and one of the co-founders at Cradle. So Cradle, the Connect system, is the only TV-based video calling and IoT wellbeing platform. So with Cradle, we decided to, rather than go the traditional route that many technology companies seem to follow, which is fit the person to the technology, we decided to fit the technology to the person. So use something that everybody is familiar with, and it doesn't create any anxiety, which is their own TV. So the Connect Hub sits on top of their existing TV at home. So the Connect Hub only needs to go on top of the person's TV at home. Everybody else in that person's network, we call a supporter. So that could be a son or daughter, a district nurse, a social care worker, or a charity. Everyone who is a supporter simply requires the Connect app on their phone, or they can access Connect via their web browser on their PC or laptop. So only the person at home needs the Connect Hub on top of their TV. So it's their existing TV that this goes on top of. And it connects via Wi-Fi, Ethernet, or if they don't have Wi-Fi, it has an integrated 4G port. So the problem that we're seeking to match this solution to is really a commonplace problem, which is social isolation, which is a growing, increasing concern, but also a very reactive healthcare system, which tends to deploy difficult and complex technology for older adults in particular, such as iPhones and iPads, which are small screens which don't help, but also require to be charged. So much of the feedback that we get from the NHS is when they try and call the user, the iPad or phone isn't charged. And lastly, when you get over a certain age, leathery fingers make it quite difficult to navigate. small screen. So we're using a person's existing TV, which makes for a much better conversation and also a wellbeing platform. So in terms of the Connect system itself, the Connect Hub sits on top of the user's TV at home. It has an automatic privacy shutter, a motorized privacy shutter, which sits in front of the camera. So the only time the camera is ever exposed to the user at home is either when they're taking a video call or making one. This is really important for privacy, dignity, and also anxiety. In terms of the interface, it's just driven by a simple yes or no system. So there are no complex questions here. Make a video call. Would you like to access your photos? Would you like to watch a video? That sort of thing. And lastly, the Connect Remote, which is really the only thing that the user will ever interact with, mirrors the on-screen experience. So simple yes or no buttons that mirror the on-screen experience. So making everything simple and intuitive. The remote control itself has large buttons, so it's been designed with older adults in particular. And therefore, if you just tremor over the button, it wouldn't do anything. You have to actually go the travel distance. So in terms of the types of users, which every deployment of Connect creates, firstly, you have the user at home. So the user at home simply uses their existing TV with the Connect Hub on top of it, and they interact with the Connect Remote. Then you have care providers and also family and friends, and they make calls to the user at home or receive calls just on their normal devices, so they don't need a Connect Hub. And today we're servicing NHS trusts, councils, care providers, charities, domiciliary care providers, and others. Our system is also an IoT wellbeing platform. So as well as video calling through the TV, it also includes a range of different devices. Some are about wellbeing, some are about safety, and some are about health. So these are simple to use devices. None of them require any manual entry from the person at home. So for example, the pulse oximeter there would simply go onto the person's finger. It would automatically send the reading directly to the Connect dashboard for the carer to see. And it will chart those readings with the ability to set minimum and maximum thresholds so that you can see if the readings are outside of a particular normal range. We can integrate any third-party device with our platform so long as it has an open data protocol equivalent to an open API. There are four main use cases for Connect. First is loneliness and isolation. Second is healthcare. Then we have domiciliary care and also centralized support type functions, which could be sheltered accommodation, retirement villages, and similar environments. Now, around these four bubbles, you can see a number of features. So some of these features are commonplace to all of these four areas, such as video calling, video upload, messages, reminders, photo upload. But some are more bespoke, such as healthcare and domiciliary care might rely on health IoT devices. Loneliness and isolation might rely on our feature around TV to TV calling. So if Betty has a Connect Hub on top of her TV and Margaret has one, they can call TV to TV. And next month, we're also releasing a feature which we call broadcast, so the ability for one person to stream live to all of their Connect Hub users. And that could be live exercise, day center activities, you know, the local coffee club or book club, or even the Sunday church service. So it's about bringing community into people's homes. So that was a relatively quick run through of the system. And what I'd like to do is just quickly in the last minute or so, just share some of the experiences that we've had with our customers in the UK and also in Europe. So the system is very easy to use for all users, so there's no training required for anybody. In terms of the way it's being used in the NHS and social care, it's being used across pathways such as virtual ward, respiratory care, long-term condition management, reablement services. And care homes are increasingly using our system as well, where it might go into a communal area or it may also go into the residence room itself for loneliness and isolation video calling with friends and family, which of course through the COVID pandemic has drawn quite a lot of attention. So I hope that was easy enough to understand in terms of the system and the way it operates. If you have any technical questions around how the system operates, I can try and field those as well.
Rupinder, thank you very much. that's a really interesting presentation, and it's not something that I've seen before. But I know that I tried to teach my mum how to use an iPhone recently, and I completely get the whole thing about the distance of travel on the buttons, because it was one of those ones that had the haptics, and it just completely blew her mind, I think. So that's really interesting, and I can see lots of potential applications for your system. I don't know if Patrick has any questions coming in at the moment, or do we want to?
Yeah, I've just asked some of our backroom staff, let's call them that, to collate some of the questions or whatever. Because we're running a wee bit behind time, we'll gather them up, and then if there's any questions at the end for Rupinder, then we'll come back to them.
Okay, great. Thank you.
Thank you.
Thank you,
Thank you
Rupinder.
so much, Rupinder. That was great. And our last company that we're going to hear from is called Healthy Kids, and we have Chris Cousins here from Healthy Kids to tell us about their work in this area as well. So welcome, Chris. Hand over to you.
Thank you very much, Janice. I'm hoping you can see my screen, all being well. Let me see. Perfect. So I assume everything's going fine. So again, thank you very much, Janice, and obviously thank you very much for allowing me to present the Healthy Kids program to you all today. So Healthy Kids is a community interest company and social enterprise that started in 2014, fundamentally as a coaching organization, delivering holistic health and well-being lessons, as well as the PE curriculum to over 150 primary schools and 12,000 pupils across Northern Ireland. Our overarching aim was to give physical education and health the same level of importance as numeracy and literacy on the national curriculum. Our program works hand in hand with the Children and Young People strategy, which states to improve the well-being of all children and young people across Northern Ireland, delivering positive, long-lasting outcomes.
Sorry, Chris, I'm just going to interrupt you there. You've got the same problem that Rick had, so you're sharing your desktop, which means we have that kind of infinity image. So if you want to stop that and go back out, and then go back into share screen and just share your application window if you're running a PowerPoint.
Yeah.
There you go.
So post this up. Perfect. And we're back in again. Apologies for that. Excellent. So again, as I was saying, our program very much works hand in hand with the Children and Young People strategy. Also, there's a large body of research to support the role of physical activity in young people's lives. It improves bone and heart health, cardiovascular fitness, muscular strength, reduces symptoms of anxiety, while increasing confidence, self-esteem, and happiness. It enhances academic attainment, cognitive performance, focus and concentration, as well as memory function. The benefits are endless, but yet it still doesn't play a key role in the everyday life of a child. So why is such a program required? The Department of Health in 2020 found that 27% of children were either overweight or obese in Northern Ireland. The Children's Sport Participation and Physical Activity Study from 2018 found that 13% of Northern Irish pupils achieved their 60 minutes per day, a guideline recommended by the World Health Organization and governments around the world. They also found that just over half of Northern Irish pupils receive PE 2 times a week, with 18% of pupils receiving 30 minutes or less of PE per week. It is clear that the current PE curriculum and structure is failing our children and failing to revert the growing obesity crisis worldwide. In the wake of COVID-19, lack of routine, structure, motivation to exercise, coupled with an increased calorie intake, means that children from low-income households are at significant risk of obesity and associated metabolic diseases such as diabetes, as Mark alluded to earlier. Post-COVID-19 pandemic, health and well-being is now a top priority in our local primary schools, and Healthy Kids are able to help. We have used COVID-19 as an opportunity to accelerate our business into the digital world, allowing us to scale our business to a different level. We introduced to schools our holistic health and well-being digital platform, giving schools the ability to record, report, and reward pupils on their activities. The Healthy Kids Virtual Buddy app allowed pupils to record their daily activities in exchange for points, trophies, and certificates outside of the classroom. Teachers had access to PE lessons, cross-curricular lessons, daily mind maps and content, mindfulness videos and journal, emotional well-being lessons, nutrition lessons, as well as much more. They could record these lessons on our teacher's dashboard to then generate end-of-month and annual reports and certificates to show how much work has been completed. Using the latest international normative data and our own data collection, we have pioneered the creation of a standing measurement for fitness, allowing us to compare pupils to other pupils in their class, school, county, country, and to the international norms. Interventions can then be put in place for children who score below average, focusing on improving the various fitness metrics. Through the application of outcome-based accountability approach, we are committed to assessing our impact through how much activity we have done, how well we have done it, and most importantly, is anyone better off as a result? Partnering with CHIC and Healthcare Analytics has allowed us to build upon and improve our dashboard and app. This will allow healthy kids to integrate data collection from wearable devices such as Fitbit and Garmin to accurately report a young person's steps, sleep, active minutes, and sedentary time, metrics based off what a healthy child looks like by the Canadian 24-hour movement guidelines. CHIC researchers will use data collected from wearable devices to generate personalized behavioral interventions to promote children's physical activity, something Rick alluded to earlier. CHIC will also use state-of-the-art data science approaches to generate tailored interventions for the young person. These personalized tailored interventions are sent to the Healthy Kids smartphone app to promote physical activity and instill behavioral change in children and parents alike. We will make teachers' lives easier by reducing workload and having an evidence-based approach to what goes on inside and outside of the classroom. Driving every facet of our holistic approach will be an interactive automated calendar, supplying teacher, parent, and most importantly, every child with activities, targets, resources to follow, both during the school day and until they go to bed at night. There is a desperate need for a joint-up approach or a synergy, to use Mark's word, to tackling health and wellbeing issues, not just in Northern Ireland, but across the world. Stakeholders working in silos to achieve this simply isn't enough. Healthy Kids are committed to creating collaborations with organisations such as CHIC, governmental departments, research organisations, schools and communities to make the next generation a healthy one. A healthy child turns into a healthy adult. Healthy adults turn into a healthy community. Healthy communities turn into a healthy society. Healthy Kids is the foundation and is the first step in achieving this. Just like to thank you all for listening, and I'm happy to take any questions you may have.
Thanks, Chris. Very interesting again. From my point of view, it looks a lot more engaging than anything that was going on when I was at school to encourage me to do physical activity. I did a lot more outside school, I think, than I did when I was in school. So isn't it really important to find what people enjoy? And especially at a young age, I guess it's very easy for children to disengage if it's something that they don't feel that they're enjoying. So I think maybe your system can help with that as well.
Massively, and from the outset, even from our coaching days, and like it is still a large branch, it's very much non-sport specific, because you're only really catering. We talk about a 10-10-10 model where you have 10 people who are interested in sport and will do no matter what you put in front of them. You've got 10 that will go either way and will either take part or not take part. They're not really too bothered. And you've got the 10 at the bottom of the class that won't do anything because they're not interested in sport. They're not interested in physical activity. So we are trying to engage those bottom sort of 66%, because the top 10, they're always going to do physical activity inside and outside of the class. It's those bottom 66% or those bottom 20 of the class that you were trying to engage. And it's the age-old question: how do you motivate the unmotivated? And doing it through a system of sort of non-sport specific lessons to try and engage as many people as possible is what we think is the biggest way of achieving that.
Thanks, Chris. That sounds really good. So I think what we're going to do is save up the questions for the end, maybe, if you're still going to be with us, hopefully, at the end. And we'll, I'm just going to say thank you, Chris, and we'll move on to our next presentation, which is a case study. And this is, it's an interesting project, which, as I said earlier, was funded through, originally through R&D Division and the Atlantic Philanthropies, and then through the Digital Health and Care Northern Ireland team with Stu. So I know that this is going to be a double act, so I'm going to hand over first of all to Professor Maurice Mulvena from Ulster University, and then Sue Hun from Health and Social Care, Digital Health and Care Northern Ireland. So over to you, Maurice, and very welcome, both of you.
So Hun, you're on mute at the minute, so if you could just unmute yourself.
Yep, thank you.
Okay, well, thank you very much, everyone. Thank you, Janice, and thanks everyone who set this up. I don't have a lot of time, so I'm going to run through this, and it is going to be on YouTube, and you can replay it at half speed if that helps. I'm going to try to cover a few things that we have that have come up from Siobhan's talk and from Mark's talk and so on. So I'm just hearing some feedback from someone maybe who has a microphone on.
So are you broadcasting the YouTube channel on a separate browser window or anything, Maurice?
No.
Okay.
So I'll continue anyway. So this is about a study that Sue will also talk about, and this was a research study funded by the HSC R&D to build an app to take part in to facilitate a study of reminiscence to see if this digital intervention for people living with dementia and their carers would be of any value to the carers and the people living with dementia. So we built this rudimentary app, and we can see some of the reminiscence images and videos in this here, including actually a photo of the family of the developer of the app sneaked into the image. So this was a rudimentary app, but in developing the app, we built in code which would capture anonymously the usage of each of the apps. And this was a study with 30 dyads with 60 people with dementia and carers together. Quite a few years ago, 4 or 5 years ago now that we ran this. So we could see for the first time from this digital data that at the bottom left, you can see that the sort of turquoise colors, PWD, people living with dementia, who were using the app for reminiscing in the wee small hours. So it would have been impossible to ascertain that information without the use of the digital data. And we can also see that there are troughs in the 24 hours of the day as people drop off reminiscing to have their meals and so on. So we're getting quite interesting descriptive statistics. Siobhan mentioned ecological momentary assessment, so that you can ask a question to someone using an app. It's ecologically valid in psychological terms, so the person doesn't have to recall being asked in a survey after the event. That's why they're using it. So think of a pop-up as you're using an app or a website or whatever. So in our study, we were able to use the primary outcome measure of mutuality and ask questions about that. So never mind the actual answers, but we were able to work out that a Tuesday evening around 7 was whenever most of the people presented with the question elected to answer it and not to dismiss it. So we were able to find very useful information about when we would ask people questions through the app. And then thirdly, we used machine learning. We used data analytics to discover if there were behavioral patterns by the usage of the app. And here we can see 3 ovals representing 3 different kinds of users, and there's a 4th person in their own cluster up in the top left for the eagle eye amongst you. So we can do an awful lot from this digital data. And the HSC, the Department of Health, Public Health Agency, loved the results of this study so much, they worked with us to support the procurement of the development for a real app that could go live in the app stores, and Sue will talk more about that. So this is what it looks like. This is what it looks like if you put photos in it, and you can reminiscence with it. And in reminiscing, again, anonymously, you're generating data, which is then available for research purposes. And we're seeing this modality increasingly apparent across the academic community around the world, with the increase in digital health interventions that people can use, and the health service can use the usage data to improve the service and build an evidence base on the service. Just hot off the press from yesterday, I have a final year undergrad student, Kieran Malarkey, who has done the same kind of 24-hour graph based upon the usage of the app that's out there on the Apple and Google Play stores right now, with maybe 400 or 500 downloads to date. So the numbers are small, but you can see that it's got the same kind of shape of peaks and troughs around the day as people reminisce more and less at different times. So This is showing that we've gone from a research project to a real world app, but still generating research data for the research community, as well as the commissioners of this, in effect, a new service for people. And my final slide here, Sue, is to bring out some concepts that are appearing in the literature. The first is this idea of data in the wild. So it's not data that's coming from an outcome measure that's designed in the study. It's just data. It could be accelerometry data from your phone or your smartwatch or whatever, sometimes called found data. And then there's real world data, which is akin to found data. This data is, this is again your smartphone, your Strava data, your Fitbit data, and so on. And again, there's a link to the FDA article on this. Siobhan's talked about ecological momentary assessment, so I won't bother. An important idea relating to some of the comments about data protection and privacy concerns from Jackie and other people in the chat. I've noticed that consent is still way behind the digital world, but some researchers, and a link here to an article in Nature, talks about the concept of dynamic consent. So for our Inspired app, users can withdraw their consent at any time. So this is, in effect, what dynamic consent is. And finally, Siobhan has also mentioned this idea of a digital phenotype, and it's just a language we're seeing used increasingly. This is the expression of a person's behavior, just as genes are expressed in what a person looks like and so on. So to then a digital phenotype is the expression of a person's behavior from their digital tracks that they leave behind. So these are all concepts that we will be getting used to over the coming years in using digital health. So thank you very much. Just like to acknowledge the HSC R&D grant that supported the original study, which had Professor Sumter Ryan as the PI on it. So thank you very much.
Soon you have some slides you wish to share with us.
Sorry, is that for me? Patrick didn't catch the beginning of the call. Hi everybody, my name is Suhan. I am the Innovation and Ecosystem Lead for the Digital Health and Care team in Northern Ireland. So I'm going to just dovetail on what Maurice has said in terms of how the health and social care system facilitates development of such endeavors in digital innovation, because we have to kind of tackle through some of the barriers that we see existingly at the moment. So I'm going to share just a quick screen share of my window. So really, dovetailing into what Maurice has said, we had a project which was the aim was to actually allow people to find safe and trusted apps for information and guidance for people living with dementia.
Sorry, just let me interrupt you. Again, you have shared your desktop. Do you want to go?
Oh, I thought I shared the screen. Right, okay. Give me a minute here. Yeah. No. Is that better? Is that better? No?
Yeah, we're still just seeing desktop. So when you click share video, it will give you the option to share desktop, share application window, or share tab. So you want, if you're going to share PowerPoint, you can just click on the application window.
Yeah, that's what I thought I was doing. No?
Okay, here we go.
Yeah. Okay. So essentially the aim of the project was to allow us to find safe and trusted apps for people living with dementia, as well as healthcare professionals, Because one of the barriers, I think, for a lot of this digital innovation is because of the regulatory and the governance arrangements with regards to healthcare professionals making recommendations or referring people to use apps. And because there is nothing at the moment to kind of give that assurance to them, so we needed to find a place and a framework that allows people to be able to find safe and trusted apps that maybe are reviewed from a few perspectives. So what we then did was we created, to facilitate the apps like what Morris has done, we created a dementia apps library where we think that the process of review that the organization that does this for us, that built the library for us, is an organization called OCAR, which is Organization for Review of Care and Health Apps. What they do is they really review each app under 3 criteria. First, on professional assurance. Secondly, on data privacy. And then thirdly, on usability. So from those, then we were able to then at least give a certain level of comfort and assurance, both to people living with dementia, their carers, or healthcare professionals on the actual quality of the apps that we were going to put on the library and that we were going to recommend for them to use. So to that end, we then developed this app for dementia library, and we put it into the kind of 5 categories of information and guidance, carer support, active minds, communication and memories, and staying well and calm. So some of the apps that Morris has developed and as Professor Sumter has developed on the Inspired app, that falls into the kind of staying calm and information and guidance, but also keeping, kind of active mind. So they fall into a number of categories. I'm going to stop sharing and go into the video piece now, because I would like you to hear from the healthcare professionals and the people living with dementia on where they see how they see. Can I just share this?
Really useful. Sometimes it is quite difficult to discern the apps. We decided to create an apps library because we know ourselves, whilst apps are really useful, sometimes it is quite difficult to discern the apps which are really right for our use. OCHA is an organization who has experience in reviewing and validating apps. We are going to encourage our healthcare professionals to apps to the patients and their carers. So therefore we need to be sure and to have the confidence that the apps that we're putting on the library are clinically assured, takes into consideration data and privacy issues, and as well has the right usability that will actually be suitable for people with dementia to use.
Yeah, my name's Jack Cash. I'm 68 years old, and I was diagnosed with vascular dementia about 18 months ago. It's just the changes, the changes come, and the changes are coming, and you see it, you try and deal with them, but it's just something that you have to fight, and that's what I'll do.
Jack's a very active person, always has been all his life. His passion is his table tennis, which he's played from I ever met him. Well, for me personally, I'm not really great into the IT, but under the circumstances with Jack's condition, I find that it's an important thing for me to learn now. Every individual is different as to what works for them. We know the app library's there now, and what we do is we look through it, decide what we feel as a family, as we know Jack well enough as to what would suit him. The Life 360 has been great. It gives me great confidence when he's out. At least I know where he is. If he doesn't return home when he's meant to, at least we know where to sort of start looking for him. Especially the carers and family. Go in, look at all these apps, find out what suits the person, your member of family, whatever, because they really are really beneficial.
Part of my role is to assess people to help and aid the diagnosis of dementia, but also to provide early intervention for people with memory difficulties and who have just been recently diagnosed with dementia. I think the apps library is very useful for professionals. We would be recommending people to use different apps to support them in their everyday life, particularly through the memory rehab program that I would do with clients. There's so many apps out there whenever you go online to search, and it's very difficult to find the most appropriate app or to find safe apps, and I think the app library gives us professionals just a wee bit more confidence in recommending specific apps to our clients.
I've had dementia for about 5 years. Apps is a new thing that has come in, and they're obviously very, very good. You know, you can get people there who are having difficulty maybe sleeping, for example, maybe doing other things, and apps can have a place for people who've got situations like myself.
We find that the apps are particularly useful for people who have communication difficulties, who are looking to keep their brain active, or looking reminders about medication, appointments, reminiscence type apps. There's a whole range of apps out there that we're finding are very useful for people with dementia.
So I would strongly recommend, if you can use them and you're interested in them, they're a great help.
So yes, so that's kind of sums up the library that we've got to date. And we've also now built a library which is for our user for non-dementia use, which is kind of general library. So that library can be found, which it has got mental health apps at the moment. It's got fitness, nutrition. That library can be found on the apps for healthcare ni.hscni.net as well. So thank you.
Thanks, Sue, and that was a great demonstration between the two of you, Morris and Sue, of how we've been able to take something right through from concept, through research, through knowledge transfer and exchange, and into practice. So yeah, that's a really interesting case study. And I don't know if we have some questions, but I hopefully we can just keep those until the end, Patrick, and if you were able to stay.
Yes, I've asked Pascal and Barry to collate some of the questions, and then if we have a wee bit of time at the end, we're kind of already overrun, so we'll see how we are after David Branagh's presentation, and if all the presenters can stick around, then I think Pascal's going to come on and ask 2 questions in the panel. So thanks again to Morris and Susan. Thanks for your contributions today.
Yes, thank you. And next up, we're going to hear from a really important part of the workshop is to hear from David Branagh, who is head of CHIC, and he's going to tell us a bit about how you can progress projects with CHIC and just basically how you can link up with cross health, Northern Ireland health and social care and academia and industry.
Thank you very much, Janice, and welcome everyone. I'm very conscious of the time. I'm going to try and go as briefly through our slides today as possible, which hopefully you can now see. I've recently been reading Simon Sinek's Start With Why, and we've seen and heard some wonderful insights and solutions today. But I thought it might be useful just to share a little bit of the why of CHIC. Really, ultimately, we are aiming to transform healthcare and improve patient outcomes. We are business led though, so we're looking to have an economic benefit as well. We have a few broad research themes. Many have been brought into focus through recent healthcare developments, including COVID-19. But they span smart living, adding technology to the home place, to medical sensors and diagnostics, including the now ever familiar lateral flow devices, to things like IoT, which we've mentioned today, analytics, and living lab, or observing people in their own surroundings to be able to develop products and solutions which more accurately meet their needs. So a lot of it is around identifying unmet need, doing some early research, and helping that translation of a research of a question or a problem to something that generates a bit more insight or an early prototype. We are industry-led. We run industry-led projects. So what we actually do is deliver projects which typically might last between 3 and 12 months, of the order of 75 to 150,000 pounds, on a collaborative project from our members. We're based at Ulster University. We have and funded by Invest Northern Ireland, but have close links into Queen's and the HSC as well. So we're very much trying to have a multidisciplinary approach to the research and the solutions that we generate. Typically, we'll have calls for projects twice a year, and have an application process for that. We have about a dozen researchers in CHIC to deliver our research and outputs from a very broad range of capabilities. I suppose for today's session, maybe some of the more important ones are around the user experience, the machine learning and AI approaches, and some of that social nudging and aspects related to that, which are often deployed in our solutions in our research. A typical CHIC project, whenever we have a call for projects, we're keen to be involved in the formation of a project, coming with a proposal for the area of focus for that project, dealing with industry partners and healthcare experts and organisations to really form a project that will ultimately deliver some useful insights. So, sort of very briefly, left to right, we're helping to form a project. We'll deliver that project, but ultimately, it's very important. The right-hand side of this slide, we want the outputs to have impact, to be taken back into industry, commercialised, and have an impact in healthcare, as well as lead on to further research. We have benefits both to business and healthcare in identifying that unmet need, and researching a possible solution. So we're sort of seen as a linking function between academics who have great ideas and insight, and healthcare, and the sort of the coal face where we'll see that real need. So it is really, companies have this need to access healthcare and fully understand the unmet needs, and we also have innovations in the healthcare sector who maybe the only route to bringing that impact and that development is through a commercial organisation. So we're sort of fostering those links and bringing those together. I have a very few slides just to give you a flavour of some of the projects we've worked on in the past. We had a project using a thermal camera in a domestic setting or a care setting, really to look at occupancy and agitation, which may be one of the sort of symptoms of dementia, to provide that extra level of care and assurance that things are as they expected to be. We further developed that project into a box which could be delivered in the post, arrive in someone's door, and incorporated a number of sensors to allow them to be easily installed in a person's home and provide, as say, that level of monitoring and assurance that the loved ones are doing what they normally do, and that everything's okay. We have another project looking at diabetic foot disease, and diabetes has been mentioned by a couple of our speakers today as how prevalent it is, and how that's only going to increase with increased levels of obesity. We expect to see diabetic foot disease is a real issue, a complication of diabetes where ulcers on the foot can ultimately lead to lower limb amputations very frequently. We looked at a solution using a thermal camera to look at preventative monitoring for diabetic foot disease. and brought that through to sort of a prototype solution. Another product looking at reducing readmissions due to heart failure, very frequent complication when people are discharged from hospital, that the medications or their changes to their daily routines don't sort of match their new health condition. And this will provide a means for the person at home to more closely monitor their health progress and also report that back into a clinical setting. We've worked with one of our local companies, Lecky Design, to add some sensors onto one of their mobility aids, really to give them more data around use of the system and progress or regression of users in this. And you heard from Cradle previously. We've done a few projects with Cradle, one working on some analytics and incentives around social isolation and the product they have, and are looking some further work around activities of daily living and things that we can derive from that. Just our penultimate slide here. These are some of the partners and companies we work with in Northern Ireland. Hopefully, arising out of this series of talks, we'll make a few more partnerships and continue to work with the companies in the healthcare sector, really, as I say, identifying that need and bringing solutions. Just as I pass it back here, hopefully within my time, we haven't lost any more time. I'd like to thank Janice for chairing this and the people in the background, Patrick, Pascal, and Barry, Jessica for drawing it together. And I'll pass back to Janice to take it from here.
Thank you, David. So we're getting pretty close to finishing now, but I think we've got Pascal coming back on with a couple more questions. But while he's getting in position here, I suppose just to make best use of the time and say that we hope you've enjoyed the event today and that you will be interested in joining some of our future events. We're hoping to start with something in cardiovascular and respiratory, and then we'll be following up with a feedback form, which we'll be sending out to see your feedback on this event and how to stay informed about our future events. So yeah, I just echo David's thanks to Barry, Jessica, Pascal, Patrick, to all of our speakers and the audience. And I'm going to just let Pascal now jump in and see you're all in place and ask some of the questions that the audience have been putting forward.
Hi there, Janice. Yeah, so thanks for that. So as Patrick has said, there's been a number of questions put forward. We've also noticed that some of the questions people have been going back to on the chat box and actually responding to, interactively as well. So I'll go to some of the most recent ones. So there was a couple of questions for Rick, particularly given as a keynote speaker. So one of the questions for Rick was, what are the main friction points that they've experienced or that he feels needs to be addressed to facilitate the increased digital technology uptake by both clinicians and healthcare workers?
I'm sorry, what are the what?
That you mentioned around the friction points. So
the friction points, yeah.
What do you consider to be the main friction points that need to be addressed?
So in the United States, we often have a portal that a health plan makes available to its members, and some people can't find the location on the portal that tells them what to do and how to do it. There are apps that are hard to download for non-digital natives. There is the age-old username and password, which are lost or confusing and can't remember which one is for which. There's a two-factor authentication, which is defying the logic of those who are seeming to get in without friction. So those are just a few examples of the walls and barriers that exist between a consumer needing help and a provider trying to give help.
Okay. and next, and I think this is more of a general question around the whole topic of technology and wellness. So, and making it thought it would be relevant to the current situation. So the question was, how has COVID impacted and changed how individuals, clinicians, and healthcare systems view the use of the technology for well-being now, following the events of the last 12 months? So I don't know who would like to address that one, but like if anyone wants to butt in at this point, you know, and provide a response, then please do.
Yeah, it's Morris here from Ulster University. I think Sue was mentioning ORCA earlier, and the statistics that ORCA have talked about in their recent webinars show a massive increase in the download and use of mental health apps. So there's been a great increase across the board in all kinds of digital health, self-care and self-management services and apps, but the biggest growth has been in mental health area, and that includes chatbots as well.
Okay. Rick, there was one person looking to get in contact with you specifically around developing a venture. So I think Barry Anderson has suggested that he can get you in touch. So
Sure.
I just want to make you aware of that. But as I said,
on that last question, Pascal, I think adding to Maurice's very cogent response is the fact that we no longer have a doctor-centric world. The doctors are having to come to our world because we spend 99% of our lives living outside of their offices, and yet the healthcare system's been built around them and convenience for them. So that, I think, is the major shift that COVID brought for us.
Okay. As I said, I think we're all very aware of the time here. It's 5 to 4 here, so you know we've gone well over time. So I think I'd just like to hand back to Janice, if that was okay, just so she can say the final farewells for everyone. I suppose from my point of view, I'd like to thank everyone. It's been a well-participated event. We've had good numbers, both registering and looking on the YouTube and the Twitter links. So thanks for all your participation. And as I said, just hand over to Janice here to wrap up this event.
Yeah, I'm going to be really, really quick. So I just wanted to say that it's been absolutely great to hear all of our presenters today, and all of the information that's been coming across has been very interesting. We have got a really big audience, which we're delighted about, and an international audience, which is great. And we always talk about these events, and all these things are all about people. And so if you walk away from here with one thing that you've been found interesting, please do get back in touch. Don't just wait and to see if somebody else reaches out to you. If you find something interesting, get in touch. You'll see the ticker tape that went along the bottom with contact details for both HSC R&D, Barry's contact details, and CHIC. So just get in touch, and we'll try and take forward some exciting developments from this workshop. And we look forward to welcoming you to some other workshops again in the future. So thanks very much, everyone, and enjoy the rest of your day. Bye.
Thank you. Bye-bye.
Bye.
Thank you.